The last two talks are ADQI updates. The first one is AKI in liver cirrhosis. That's ADQI 29, and the speakers will be Mitra Nadeem and Akash Deep.
Thank you, Ravi, for inviting me and Akash to present this. And sorry, Sean, there's still 2 more talks before you get your actual drink. So anyway, over the next 15 minutes, we're going to go. We selected certain recommendations that we thought to highlight. This paper has been actually accepted for publication in Journal of Hepatology. It should hopefully be out in the next few weeks. Okay, let's see here. These are disclosures. So just some quick background. Up to really, for the first 30 years, so from 1979 to really 2012, there was no definition for AKI in patients with liver disease. The only definition was hepatorenal syndrome, which was based on a creatinine of 1.5. If whoever was doing any kind of study felt the patient did not have hepatorenal syndrome, they were not included in any kind of study. And then in 2012, ADQI published the first definition really of AKI, which really was to say use the AKI criteria that was at that time. Subsequently, in 2015, the International Club of Ascites updated those definitions, basically using the KDIGO guidelines instead of the AKI criteria, and made some revisions to the HRS definition. And last year, exactly actually around this time, the ADQI group and the International Club of Ascites, a few members, got together and came up with new recommendations for definition of AKI and HRS. And this was held in San Diego last year. The organizers were myself, Ravi Mehta, and Francois Durand, who's a hepatologist and intensivist from France. And the faculty included 30 faculty from various disciplines: nephrologists, intensivists, hepatologists, surgeons, pharmacists. So you can see it was not a very easy ADQI to get through. So the first group was tasked with epidemiology and definition of kidney dysfunction. And on the left, you'll see the last definition for AKI was, again, based on the serum creatinine criteria for KDIGO. This was accepted by the International Club of Ascites. And they did not include the urine output. And the rationale for the International Club of Ascites was that these patients are frequently oliguric. They have increased urine output due to diuretics, and it's difficult to collect urine, so it was never included. So the recommendations that were made by the ADQI-ICA group was really to include the urine output, that AKI would be the KDIGO criteria for AKI, and AKD and CKD should be aligned with, again, the definitions that currently exist for KDIGO, and the recovery for AKI would be patients basically getting back to their baseline serum creatinine of 0.3 of their baseline. And the urine output, again, is very important, and this was the rationale for the recommendation that we made. This is a study from John Kellam's group. He was inspired by the first ADQI where urine output was not allowed to be included in the definition for AKI. And so he looked at the patient population in Pittsburgh, 8 ICUs, and you can see here patients who did not meet serum creatinine criteria. These are patients with liver disease, and that's in the first row. But they met urine output criteria for stage 3. They had a 22% mortality rate. And combined with serum creatinine criteria, the mortality was quite high. And that was the rationale for us pushing really for this ADQI-ICA to include urine output in the definition. What about the reference serum creatinine? Again, there's been a lot of debate over just outside of the liver world. What should you use as your reference? And some patients may have baseline serum creatinines, but some come in no known history. Should they be using the hospital? Should it be the lowest during the hospitalization? And again, on the left is the International Club of Ascites' current use. If the serum creatinine in the last 3 months to use that. If there's nothing available, the closest to the current one, and if there's nothing, then to use the serum creatinine. And again, there was a lot of debate for the members, many of them are in this audience who were there. There was a lot of back and forth going. And so we finally, I should say, were able to convince the hepatologist to, again, follow what the KDIGO for now has recommended, that if you, well, let me start. If you should go by the first, within the last 3 months, if you do have a baseline. If you don't, we said 12 months, but again, clinical judgment should be used. But in the absence of a known baseline serum creatinine, that the reference should be the lowest of either your serum creatinine on admission or a back-calculated value of an estimated GFR of 75. And again, this was a lot of pushback from our hepatologists. It was, and that's why it's a suggestion with the weak recommendations. But there is data. Again, this is John Kellam's, the same study on the table. I just cut out the section for it, but on the baseline characteristics, if you look for patients who did have a known baseline serum creatinine, if they had used the hospital admission or the reference based on, again, a GFR of 75, you can see the reference was much closer to the known baseline rather than if they used the hospital admission. So again, it's either, if there's nothing that exists, our recommendation was, again, to follow the KDIGO recommendations. But of course, I guess KDIGO is going to change in 2 years, so we'll have to have another ADQI meeting. So what about the definition of HRS AKI, so hepatorenal syndrome? Again, on the left, you can see the definition changed in 2015 when they removed the serum creatinine of 1.5, but everything else remained the same. They still kept the 2 days of albumin use, the absence of shock, absence of other nephrotoxic agents, and the structural damage, if it existed, that excluded patients. And our new diagnostic criteria is patients, they have to have cirrhosis with ascites. Again, the KDIGO definition of AKI would be both serum creatinine and urine output. Absence of improvement in serum creatinine or urine output within 24 hours, not the 48 hours anymore, following adequate volume resuscitation when clinically indicated. And again, there's a lot in the rationale of the discussion we've put in the manuscript to state what we mean by, again, clinically indicated. If you're volume depleted, hypotensive, then you don't need 25% albumin. You should give them crystalloids or balanced solutions. If you are fluid overloaded, intravascular volume overloaded, you have JVD, you have pulmonary congestion, elevated RV systolic pressure, they don't need anything, nothing anymore. You actually have to start figuring out how to treat them, whether it's diuretics, dialysis, terlipressin, you need to start treatment. For those who you can't make a decision, you have 24 hours. You can either, again, the hepatologists still love their albumin, or you can give 250 or 500 cc's of just regular fluid. In the absence of strong evidence for an alternative explanation as the primary cause of AKI. And this is to reinforce that these patients can have two things going on at the same time. They can have hepatorenal syndrome and have, vancotoxicity. It's not an either or. They can have underlying, again, proteinuria from diabetes and can have hepatorenal. So the question becomes, which one is the driving force for the AKI? And we put a consensus statement again. Even the reviewers had pushback on this, but we stuck to our decision, is that we recommend against systematic administration of albumin for 48 hours as a requisite for the diagnosis of HRS. That has been removed from the clinical diagnosis.
Thank you. So group 2 focused on pathophysiology, and we made a point to have a focused discussion because we understood that there's a lot to do with pathophysiology and the management, how it's going to take place. Now, if you look at previous literature, it used to focus only on hemodynamic alterations. But what our group in ADQI did was to have a consolidated approach on the various factors which can act together to have different phenotypes of AKI in patients with cirrhosis. The thing to remember is it all begins with portal hypertension. Patient has to have decompensated cirrhosis. You have portal hypertension. The portal blood gets blocked. There's lots of bacteria now in the bowel, and then takes the translocation of bacteria. Once the translocation of bacteria takes place, there's lots of PAMPs and DAMPs. You then get release of inflammatory cytokines, especially TNF-alpha and IL-6. And what they do is they release vasodilatory substances, especially your nitric oxide, in the splanchnic circulation, and that triggers a cascade of events, like hemodynamic alterations there. You have splanchnic vasodilation, you have effective circulating blood volume being decreased now, and then starts all your compensatory mechanisms, which is your renal angiotensin system, your sympathetic nervous system, and the non-osmotic release of vasopressin. And what they all do is cause vasoconstriction in the extrasplanchnic beds, especially renal vasoconstriction, and that leads to HRS-AKI. Now, in addition to the inflammation I spoke about, it's about cirrhotic cardiomyopathy, the cardiac affection, your systolic, your diastolic function, the response of the heart to various triggers, the various stresses gets blunted, and that's a major factor in adults as well as pediatrics in the causation of HRS-AKI. In addition to all these things, it's about bile acids. The intratubular casts which are obstructing, as well as the direct bile acid toxicity, is what affects HRS-AKI. So if I have to summarize the pathophysiology, I would say it begins with portal hypertension. You've got inflammation. You've got cardiac dysfunction, you've got splanchnic arterial vasodilation, and the whole cascade of hemodynamic alterations leading to vasoconstriction, and your cholemic nephropathy. Again, as I said, these things are important because they'll serve as therapeutic targets in the management of HRS-AKI.
I should apologize to our pediatric colleagues. One is out there, and Akash, because we forget they're pediatricians. They know so much about adults, but they were also involved in this consensus meeting. So group 3, which talked about workup and prevention of AKI, again, we're just presenting a few of the recommendations due to the lack of time. So what are the approaches for the prevention of AKI? Again, if you speak with many people, the hepatologists, liver AKI equals albumin. Liver disease, SBP, albumin. Liver disease, large volume paracentesis equals albumin. So we were trying to really get this across to everyone that, giving fluids comes with a cost. And so here you can see, yes, we recommended 20 to 25% albumin for the prevention of AKI following large volume paracentesis in patients with SBP. But you can see there's no amount of albumin that we have included. And again, there was a lot of back and forth with our hepatology colleagues, and we put in that statement that the dose and duration of albumin should consider patients' hemodynamic and volume status. And again, if you look at the data, there's only one article in New England Journal, 1999, so that's 25 years ago, that was published on SBP and albumin. And if you really look into the details of that, which has become like the holy grail that people really swear on day 1 and day 3 of albumin. But if you read the methodology, it was given day 1 and day 3 because that's the days that they checked labs. They checked labs on day 1 and day 3. And so they decided to give albumin in those days. And the study is supposed to be prevention of AKI, but 40% already at the time of randomization had kidney dysfunctions, which they defined as a creatinine of 1.5. And in their outcome, even though they saw a difference in outcome, if you look at the actual serum creatinine measurement, they didn't even reach the 1.5 criteria that they set as a definition for renal dysfunction. And again, finally, we've kind of forgotten all of this, but if you go back, which I did go back for the purpose of this paper to argue with the one author who had published this, is that if your bilirubin is less than 4 and your serum creatinine was less than 1, those patients did not even need albumin. It didn't make a difference in the outcome. And their own conclusion was studies should be done to decide on the dose of albumin and duration due to the cost. That study was never replicated. This is the only study really that has been out there randomized, and we use it, but really you have to think twice when you give day 1 and day 3. And I think really it was SBP, volume depletion, the group that got albumin just got volume. And then for patients with, we recommend against the systemic use of albumin in patients with decompensated cirrhosis, for non-SBP infections, and solely for the maintaining a serum albumin over 3. Again, we recommend it against. And this is, again, the highlight of Group 3's work, which we recommended that in addition to serum creatinine, to use complementary use of functional and damage-related biomarkers. And the one that's been studied the most really has been NGAL in patients with liver disease. And this figure is a figure that really was adopted, from ADQI 10. So we're now on ADQI 29 for this. So you can see this figure has been replicated over and over again. And it's really the same concept, but it's saying that patients with liver disease can have negative biomarker for functional, but they can still have damaged biomarkers. And yes, maybe that's not known yet, but they may be having subclinical AKI, and they may be the patients who are more prone to developing AKI following any kind of insult. But then the bottom you can see here is that you can have functional positive biomarkers, but negative damage markers, and these would be patients with AKI or HRS AKI, or damage marker positive and dysfunction. And again, we have their HRS and AKI, again, suggesting that you can have both of these together. Again, one of the things I forgot with Group 1 was that the AKI, depending on the duration, the hepatorenal, if it prolongs, can be AKD and then CKD.
Correlating your Group 2 and Group 4, we then focus on the management of kidney dysfunction in patients in cirrhosis. What pathophysiologic, which we discussed in Group 2, can we target? And we looked at 3 or 4 main components. You give fluids, you take out the fluid by using diuretics or renal replacement therapy, use vasoconstrictors, and we talked about liver transplantation. When we came to fluids, we wanted to talk about what kind of fluids to give and how do you monitor, how do you manage these patients when you're giving fluids. So what we recommended was you need to have a holistic approach when you're giving fluids to a patient. Have a physical examination, use imaging techniques, and use the static and dynamic measurements in guiding fluid management. And when it came to the type of fluid, we recommended giving crystalloids, preferentially the balanced solutions, as a first-line therapy in patients who are requiring fluid resuscitation. Equally understanding that fluid overload is a big thing in these patients who've got cirrhosis with decompensation, we said once the patient has developed signs of fluid overload, we should stop giving fluid resuscitation, initiate your diuretic therapy or renal replacement therapy in patients who demonstrate signs or symptoms of fluid overload. And then this is the pathophysiology we talked about. We talked about splanchnic vasodilation, and therefore we needed vasoconstrictors which specifically act on your splanchnic circulation, for example, terlipressin, and therefore we recommended as a strong recommendation, grade A, that start vasoconstrictor therapy in combination with 20 to 25% albumin immediately upon diagnosing HRS-AKI. Now, this table on your left-hand side, you'll see what the 2015 guideline said, and on the right-hand side is your current guidelines. If you look at albumin, we used to say systematic administration of intravenous albumin. Doesn't matter you're hypervolemic, doesn't matter you're hypervolemic, we used to give it. Whereas the current guidelines, we are very cautious of our volume status, and we say dose of albumin should be adjusted daily based on patient's volume status with immediate discontinuation if there is evidence of volume overload. Similarly, how frequent should you adjust the dose? There were no specific recommendations in the previous guidelines. The current guidelines say that you don't have to wait for 48, 72 hours. The dose of terlipressin can be increased every 24 hours if there is no decrease in serum creatinine by 25%, and the dose of epinephrine, norepinephrine, to be increased every 4 hours if your MAP doesn't go by 10 millimeters of mercury from baseline. What about discontinuation? When do you stop these vasoconstrictors? Again, if you look at the previous guidelines, they talked about full response, they talked about partial response. What we said was, let's have clear guidelines. When do you stop these vasoconstrictors? And we said, we recommend discontinuation of vasoconstrictors if the serum creatinine returns within 0.3 milligram per deciliter of baseline, you develop a severe adverse reaction, your kidney function doesn't improve after 48 hours of maximum doses, or if your renal replacement therapy is indicated. So this is just the last figure of this group showing the effect on various vascular beds. And very important is when you look at the effect of terlipressin, it causes a maximal splanchnic vasoconstriction. But if you look at the effect on your pulmonary bed, so what splanchnic vasoconstriction does is actually takes away a lot of blood into the central circulation now. But the pulmonary vasoconstriction, the venoconstriction, the pulmonary vasodilation, plus the increased pulmonary vascular permeability, what it does is it puts you at an increased risk of developing pulmonary edema if you're giving albumin to these patients. And therefore, what we recommend is monitor your volume status while giving albumin to a patient on terlipressin. Excuse me?
Oh, no, it's me. Yeah. Okay, sorry. Last group was, we only have 2 more slides. Basically, the last group was looking at the follow-up of these patients, and this is again a modified version of ADQI 24, where it talked about quality, and it's very similar, again, stating that as if the patient, depending on their kidney health, their liver health, the amount of monitoring, whether it's with a nephrologist, hepatologist, or combined. And again, these are the time points were really selected to be similar to what was published previously by the ADQI group. And there's a final slide.
This is the pediatric perspective. I think the fact that ADQI has pediatric representation in all the ADQI meetings, we had the same one here as well. We didn't have enough data to discuss pediatric perspectives, but what we found was that AKI is common in children with cirrhosis, carries both long and short-term morbidity and mortality. The difference is that the diseases which lead to cholestatic, like for example, biliary atresia, are the most common causes, and therefore we actually cannot extrapolate the data from adults to pediatrics. The incidence of HRS AKI is about 10%, but again, that seems to be a gross underrepresentation. But we say that the case mix is different, but if you look at the pathophysiology, seems to be the same. Therefore, they seem to kind of respond to the vasoconstrictors. Pediatric cirrhotic cardiomyopathy seems to have a big influence on the pathogenesis of AKI in patients with cirrhosis. And these are our conclusions of the ADQI. Thank you.